Thank you so much. Thank you everyone for staying for this session. It's definitely an interesting topic, one that I'm personally super passionate about. And we're definitely encouraging for you guys to participate, even to interrupt us with questions as we're going along, or just feel free to save them for the end. Very nice to meet you here in Dubai. Shall we start with a round of introductions so that we have our audience know who we are and where we come from? Would you like to kick it off?
Yeah, sure. Where I come from? Many places. Recently, I work in Orlando, Florida, but my base is many years ago in Chile. I am a pathologist. I developed a new treatment for cancer, first in class. It's a dendritic-based therapy with a phospholipid complex. So it's the evolving through dendritic-based cell, because dendritic cell is unpredictable. And after that, we have the exosomes with the other problems, require a cold chain. And when you create a new treatment, immediately appears many problems, you know. But at this time, after 11 years, PLPC has resolved many problems, all problems, in fact. So it's a very, very good treatment with many results and outcomes from real-world evidence. This platform is a platform, not just a treatment, because it has immunoceutical lines with 4 lines and backbone regulatory, you know, a new protocol to make the registration. So this is more or less my current activities.
That's really fascinating. I think we've taken a deep dive into a very novel therapeutic approach in oncology, one that we're still trying to understand. Thank you for that introduction. So I'm going to introduce myself to you guys as well. My name is Alex Filipovic. I'm a medical oncologist and a chief medical officer for a biotech company. I've been in this field for 20 years, and innovations in oncology have just really continued to emerge. And as much as I would like to speak today about these types of approaches that you've just mentioned, cell-based therapies, very, very novel, some targeted, some less targeted, but all really profoundly innovative, and really a testament to how technology has risen to meet biology, thankfully. My intention for our conversation today is also going to be to take a look at the journey of what we've been witnessing in cancer treatment through a slightly different lens, perhaps through a human lens, first and foremost, and also to ask a different question, and that is, what has drug development in oncology actually been trying to teach us about us as humans? And perhaps it's a bit of a conundrum and something unexpected, but I'm really happy to put that into context for the audience and then for, of course, my fellow panelists. But what I'm really, really curious to hear from you, from your career, and you now sitting in a chair where you've actually developed a very, very novel therapy, how have you journeyed your career to come to this place? And what are those milestones in terms of innovation that you have personally witnessed, been proud of, that have motivated you and that you've learned from?
I think that my experience, my journey is the same that any human being. When you evolve, when you confront a challenge, always is the same. So if you confront many challenges, you evolve so much. That's the outcomes. Why I passed to laboratory, report biopsies, to the clinical treatments and development in the laboratory, a new treatment, because I am not, I am recognized that we need something that like more. Why? Because I have cancer. I have cancer 15 years ago, and when I suffered cancer, my colleagues, my oncologists, obviously, say me, don't worry, Ramon, you don't need a problem, you don't need the treatment, but in the microscope, I see my lymphovascular permeation. So when you see that, you know that this is a doubt that in some moment you're going to repay in the future, because it's a sign to reapparition of the cancer. But what can I do? For that kind of lesion in the large bowel, you don't have a option of chemotherapy, no radiotherapy, no surgery. So what treatment is option for me? No one. And in these years, I listened about the Dr. Steinman Nobel Prize, about dendritic cells and about the immune memory and how they fed the residual implants or the microscopic or subclinical lesions. You know? Subclinical lesions, similar, the same meaning about lymphovascular permeation. Okay, I need that, but where? How? Because one thing, you know, is a Nobel Prize, and one thing is the treatment available for you in your city. This is very different things, you know. And I need to put so much work in this project. And finally, I get the molecules, cytokines, interleukins, what type of cells, PBMC, peripheral blood mononuclear cells, and I finally get the treatment for me. Okay, so no lesions about many years, so I think that we're going to get very good result. But after that situation, 5 years later, my father suffered cancer. And at diagnosis moment, he has 31 metastases for more than a hand of measures. And the colleagues say, don't worry, it's not so much that we can do, so we have palliative treatment, and that's all for the next days. They don't speak about weeks, don't speak about months. And my father says to me, son, not like that. Please help me. You must know something to maybe help me in this moment. And I remember this treatment, but it's different, lymphovascular permeation and 31 metastases. You know, the burden tumor is so different. I need to work something. And I remake the treatment for my father, and the result that not was some days, was 3 years. 3 Christmas, 3 birthdays. Say to the colleague yesterday, 2 cup of saucers of American Cup. And I learned in the real world the meaning of dissociation. That when you have so much burden tumor, but the tumor grow up in one direction, and your clinical status is for other direction. Dissociation, your clinical status for the tumoral burden tumor, you know. And after 3,000 patients, what do we see with PLPC? 14% total remission, 34% partial remission, 32% have no progression disease, and 12% have a dissociation like my father. And the 100%, 81.6.2 respond to the therapy. So after that, this is so much bigger for me. I need to write for this. I need to dissemination science. I need to put in the lens of the medical community. Maybe we have something very important, but like a science challenge, not a profit purpose or something like that, because it's not the idea. And some college review that. I have support from my government and put some funds to improve my investigation. And after that, we have something very big, the PLPC, with 5 papers, with 4 books, with 11 works, tier 1 in the Congress, for 3 patents. So the things grow up so much that I never can imagine. So the challenge put me in front on this material, on this issue. And I think that the journey really now start up, you know, really is the beginning.
Well, first of all, I want to thank you for sharing your story, personal and professional. And I hope that the audience has heard this well, because it's a true example of how human story leads to innovations in science. And it brings me to something that I'm deeply, deeply passionate about, that I love to talk to, and that is that behind every drug, there is a story. There is a person or a team that believed, that persevered, and that had a very personal why. And with that, if that's okay with you, I'll do a little retrospect of my own to sort of bring this together. I want to ask the audience, do you know what the word oncology means? So I've been an oncologist for 20 years. I figured it out. Well, I didn't figure it out. I've learned last year. So the word oncology comes from a Greek word, onkos, which means burden. And I really feel deeply called to dovetail our conversation from the panel that just stepped off the stage, where we've discussed that, where they've discussed beautifully how symptoms are an assignment from the body. And what better analogy and a real example in our faces other than oncology, where the word itself means burden. And if we take a look, we're here to discuss the innovations and treatments beyond chemotherapy, and what you have developed is just such an epitome of what that actually stands for. So thank you for that. But if we venture back into how the therapy started and zoom into chemotherapy. So chemotherapy was discovered decades and decades ago from an explosion of mustard gas on a ship during the war. And if we take a moment to reflect on what kind of language do we use in oncology, we are fighting cancer, battling cancer, conquering cancer, surviving cancer. It is war language. And words are biosymbols. They can harm as much as they can heal. So we've been throwing the kitchen sink at the messenger very actively for decades and decades. And then to the point of referring to what are the therapies trying to teach us, it is my true belief, after 2 decades of being an oncologist and a drug developer myself, but first and foremost a human, that there is a story there that leads us back to ourselves. So fast forward to 2011, when the first immunotherapy, ipilimumab, was approved. And then we had a follow-on with anti-PD-1s and anti-PD-L1s in 2014 and beyond. Here we now have an era that succeeded the era of chemotherapy and then came after the era of targeted kinase inhibitors, which were very specific, imatinib, Gleevec leading the game there. Now we come to the era of immuno-oncology, where the drugs themselves are teaching us that the human body can actually heal from the inside out. So we have an oncology patient that, can still get bacterial infections and recover, viral infections and recover, allergic reactions and recover, food poisoning and recover. All of these are handled by specific components of our immune system. But then they develop cancer, or the cancer manifests, and that particular arm of the immune system has decided to shut off. And here we now have a therapy that re-engages that arm of the immune system in a very gentle and effective way. And can we pause as a community to say, this is teaching us that the human body is capable of healing from the inside out? And then we get other innovations, such as loaded antibodies, antibody drug conjugates, radiopharmaceuticals, cell-based therapies. But really, what I feel like we are experiencing in drug development, there is oftentimes being derailed from the lessons into following trends and not having enough patience to follow patients and to follow biology and to wait for patients to survive. And what I mean when I say that is, for the first time when immunotherapies came about, we started seeing that phenomenon of the tail of the Kaplan-Meier survival curves lifting. And sadly, we were used to, for decades on end, with just survival curves plummeting down, right? Disease-free survival, overall survival, just plummeting down with really minor shifts to the right for benefit. And all of a sudden, we start getting treatments that lift the curve. So it means that maybe 5% or 10% of patients are living very, very long lives. And then we start combining therapies, chemo with immuno, targeted with immuno, immuno with immuno, cell-based therapies. And then those effects of the tail lifts become incremental. And then we get to the point of drug development where the regulation has to catch up with biology. And where we no longer are served well by the old endpoints in clinical trials. And from a drug development standpoint, I'm deeply passionate about it because drug development is what I do on a daily basis. And I'm sitting here witnessing that what is real life for patients and what is still a standard for drug development are currently at a mismatch. So it is my deep belief that we need to hurry up and meet patients where they're at and acknowledge what's really, really important for them and redefine what matters in terms of endpoints. Thankfully, there's some recognition of that, but it begs the question every single day in clinic for me personally, to every patient, what does healing mean to you? You know, who am I as an oncologist to decide that a percentage of X response is a success? Patients are not statistics. They're people. And so I don't subscribe to bucketing them into a complete response, partial response, or a stable disease arm. It actually really, to me personally, begs the question of what does healing mean to you? Is it cure or is it living well? And I'll pause here too. I'm curious to hear your comments about this.
Yes, maybe both. Maybe
Yeah?
both, because you want to extend survival in the patient. You are thinking and with good and high quality of life, because it does not make sense extend survival but bad quality of life, maybe both, you know. So I listen to you, and I think that is the goal of this panel, because when you speak about the oncology and the purpose and the challenge with the patients, this is real, what the physician, what the medical doctor feels in front of the patient. This is the real feeling inside of us. You know, no one is a critic, so eliminate the chemotherapy. But because many people, when we speak about new therapies, you are critic or you are the fed chemotherapy. No, it's not like that. Chemotherapy have main functional for any patients. Radiotherapy have their own indications. Surgery, your own indication. But you know what is the problem? Because we are normally said that we are treating subgroups of patients. I have this option for this type of cancer in this stage with this immune or with this function of liver or kidney function, you know? So we don't treat disease, we treat subgroups of any patient of any cancer at this stage, in this age. So if we think about that, we need to improve so much, because the challenge is not close to we win. We have so much pending task in front of us. You know, and we think in challenge and in the future. Obviously, the immunotherapy maybe is the child symbol. If not the whole idea, maybe the 90%, 80%, or maybe combined with some other innovation, maybe immunotherapy with nano device, or immunotherapy in skin patches, but the idea is very near. So, okay, immunotherapy, but many people know immunotherapy. I study immunotherapy, I have patients with immunotherapy, and the result and the outcome is not very good, like the investigation or the publicity or the papers. But what kind of immunotherapy? It's very different when you try the patient with CAR-T, try patient with checkpoint inhibitors, or biological therapies like dendritic cells. And dendritic cell, what? With cells, with exosomes, with phospholipid complex. And when you think in checkpoint inhibitors, I say in my conference in the morning, you repair one key in the keyboard, but the immune system is multiple molecules, multiple cells, and you pretend change the result, the final result in cancer with just one key in the keyboard. This doesn't make sense. So what is the problem? the problem is to repair one platform like immune system, you need other platform with many molecules, with many cells, with resolving the silencing of lymphocyte, macrophages, dendritic cells, and many cells that, because if you get repair and fix all these molecules, you offer a new terrain, very functional for chemotherapy, for radiotherapy, for surgery, and for other therapies. So we are in the same side. It's not advanced therapy against conventional therapies. No, in fact, I think that maybe conventional therapies are underindicated because if you review the indication for chemotherapy, as you say very well, this indication is from 5 or 6 decades. But in this time, don't knowing about the new therapies, about the targeted therapy, about the biological therapies. So these therapies, with this chemotherapy, improve the indication of chemotherapy. Today, many times I think, why the surgery is not the option for the patient in this stage? Because in this stage, the patient with lower burden tumor have many more options with surgery and chemotherapy. You know, when my father suffered cancer, the first that I think is reduce the burden tumor. So I talked with a colleague that there will be many favors, and I need this favor. I need that you extract the kidney and the tumor measure 7 inches. Very big tumor in the kidney. And after that, I use radiotherapy in the 4 main lesions. And after that, I have many other lesions, but I put my feet in immunotherapy. And results give me the reason. Because how someone think that it's not important to reduce the ratio of complications in the patients, reduce burden tumor? I know that many protocols for administrative purpose, it's very smart that you use your government budget in this way and not in this way. But when you are the patient, when your father, when your child is your son is the patient, you think in other direction, you know. So I think maybe like some bad judge in tribunals in other areas have another injustice for their injustice for the population. Maybe we have one medicine and one protocols for ours and other medicine from the population, and does not make sense, you know. So I think that it's more different. Dr. Tabernero in Spain several years ago say, put attention, put focus in biological therapies, because the immunotherapy at this moment is only in direction of new drugs. But the new drugs, in few years more, have a price that the governments don't pay. So what's meaning that? Meaning that this new advance is for only people, not for the all population. So I think that the solution is the biological therapies. For that reason, for many explanations, I put my direction, my focus in this. You know, Alessandra.
Yeah, thank you for that. And I think you've covered and you've also raised a lot of thinking points to take away for myself, certainly, I hope for the audience as well, because I think what we've attempted and hopefully achieved to some extent for our conversation today is to convey that oncology has yielded tremendously effective drugs. They work, not for everyone, sadly. And it's not a case of drug against drug, drug against patient, doctors against drugs, or anything like that. It really becomes a point of how do we stand as doctors and as innovators, as scientists, with integrity and with an approach that does not have to be different in that experience of treating ourselves or loved ones versus treating a broader population. And I feel that there's some ways to go there, but these discussions are incredibly helpful. And I feel like we owe it to the patients collectively in oncology, on the medical side, on the drug development, on the regulatory side, on the commercialization, reimbursement side, to meet them where they're at. We've done a lot, but there's still many facets where I feel there's tremendous room for improvement.
Yes, I think that maybe sometimes we think that the challenge is impossible.
Yeah.
But for example, in our company, we made the treatment.
Yeah.
But this treatment need a new regulation. And in 2022 appears Act Modernization 2.0
Yes.
and a new approach methodology.
Yeah.
So we need write a new approach methodology. We write it. So, but we need validation, two validation with Freyer and Barrister.
Yes.
So now I in front of FDA with all tax resolved. But you speak about the significance of onco, and I like that explanation, because maybe in medicine sometimes we forget the beginnings, and one of the beginning is primum non cere, and non-NCE, non-new chemical entity, biological treatments follow that, primum non cere. For the cancer patient, obviously, first it's important not defeat with therapies our immune system, because immune system is maybe the main resource that have to confront virus, bacteria, and cancer. So it's impossible that I am more agree with you than your words, really.
I feel like this is a really good place to wrap up, because you brought us back to the beginning, and that's where it all begins, with Hippocrates. So thank you. It was a pleasure and an honor to share the stage with you today. Thank you to the audience. We're welcoming questions.
Thank you so much. Both of them would be available around for any questions. We are on time crunch. I'm so sorry. If there are any questions which are around the room, are there any?